Good morning, everybody. I shall be talking about tips and tricks in decimate membrane endothelial keratoplasty. I have no financial interest to disclose. DMEK is currently the preferred technique of endothelial keratoplasty among corneal surgeons worldwide. It is minimally invasive, allows faster visual recovery with greater percentage of patients achieving 20/20. It induces minimal refractive shift and it is associated with a reduced risk of endothelial rejection. In the learning curve of DMEK, the most common barriers are the anxiety related to incorrect insertion of the donor tissue and failure of surgery, along with the anxiety related to donor tissue preparation. These are the various steps of DMEK surgery, which I will be covering in this presentation. An ideal case for DMEK should provide adequate visibility through the cornea intraoperatively, should have a normal anterior segment, no large iris defect, the lens iris barrier should be intact, and one should avoid performing DMEK surgery in eyes which have had prior glaucoma surgery, such as trabeculectomy or filtering tubes, or in eyes which have undergone vitrectomy, which have a deep anterior chamber or a unicameral eye. The donor tissue can either be pre-prepared by the eye bank in the form of pre-stripped DMEK donor, or the eye bank can even provide you with a patient-ready DMEK donor where the DMEK donor is pre-stripped, pre-stained, and pre-stamped, pre-loaded in an injector. The surgeon can also prepare the donor tissue either prior to the surgery or during surgery. This is fairly reproducible with about a 98% success rate. Ideal donor age should be within 50 to 70 years. An F or an S stamp can be placed to identify the donor orientation. Trypan blue can be used to stain the donor DM for a duration of 1 to 2 minutes to enhance visualization during the surgery. Tissue loss rate during preparation can vary between 2 to 20% depending on the experience of the surgeon. The loss of donor tissue means cancellation of surgery and an additional financial expense for a second tissue. To overcome this problem, I designed a device which has an illuminated base and it provides retroillumination during the donor preparation. So as the donor DM is stripped, you can find that it's very easy to visualize the decimus membrane. And this can help identify any radial tear or breaks that occur during this process and thereby prevent loss of the donor DM. You can use a clear corneal or a scleral incision to insert the donor tissue. You can place 2 or more paracenteses on either side of the main incision. An inferior vertical paracentesis is useful to prepare an inferior surgical iridectomy. Decimate stripping in the host can be performed under cohesive viscoelastic cover or a complete airfill or by connecting an AC maintainer. The area of stripping is usually 1 millimeter larger than the diameter of the donor decimus membrane. One should avoid creating an irregular inner surface. Studies have shown that with larger area of decimeterexis, the incidence of postoperative DM detachment is lower and there is reduced need for repeat rebubbling. Inferior peripheral iridectomy can be performed to prevent pupillary block associated with a complete airfill. This can be performed either using a vitrector or via an inferior paracentesis. You can perform a surgical iridectomy using scissors. There are various injectors to insert the donor DM, which are made either of glass or of plastic. The ideal configuration of the donor scroll is a double scroll configuration, and this can be achieved by a simple maneuver of agitating the fluid in the wider portion of the glass injector. And as you agitate the fluid, the scroll opens up, and then when it re-scrolls, it can go into a double scroll configuration. The open end of the scroll should be facing upwards, and one should make note of this prior to inserting the donor scroll into the eye. One of the problems associated with donor insertion is a total or partial expulsion of the donor DM, which is associated with an increased pressure in the anterior chamber or a leaky wound, which results in egress of fluid during the donor insertion. To simplify this, we have described a technique wherein we connect the AC maintainer and then insert the tip of the glass cartridge into the eye, orient the scroll facing upwards, and then we stop the AC, the flow in the AC maintainer, and then we disconnect the AC maintainer from the IV tubing. So now the AC maintainer acts like an egress point of fluid from the eye, thereby reducing the counter pressure to the donor insertion. As the donor tissue is inserted, it is easily placed in the anterior chamber, maintaining the correct orientation, and then we can secure the main wound and you can unscroll with minimal manipulation. There are various techniques of unfolding the donor scroll. Usually, I like to use two cannulas to tap the central or peripheral cornea. The anterior chamber is maintained slightly shallow during this tapping process. If the donor tissue is in a taco fold technique, we can use a short burst of fluid to shift the tissue so that the open end of the scroll is facing upwards, following which we move the tissue to the central part of the anterior chamber where there is adequate space. Once this is achieved, one peripheral edge of the scroll can be stabilized with one of the cannula, and then we can do peripheral tapping to complete the unscrolling process. The other technique would be to stabilize one edge of the DM scroll and then tap centrally, either in a carpet unrolling or a drum roll technique called the Dirisamer maneuver to complete the unscrolling process. If you have a deep anterior chamber, the unscrolling may be a bit challenging. In this situation, you can place a small air bubble within the scroll and then use the air bubble to manipulate to open up the donor scroll. And then once it has opened up, you can aspirate that air bubble gently, followed by placing a large air bubble below the donor scroll. If you have a donor scroll that's placed in the upside position, you can give a short burst of fluid to flip over the graft in a deep anterior chamber, and then you can shallow the chamber and continue with the unscrolling process. If you have a tight scroll which does not unfold, you can use the Fogla cannula, which has two side ports and it is closed at the tip. This can be inserted within the tight scroll. So you orient the scroll in the long axis to the paracentesis, then insert the cannula, give a short burst of fluid, which opens up the scroll and converts into a double scroll configuration, and rest of the unfolding is quite easy. Another technique is a pull-through technique, which is an endothelium in technique, pretty much similar to like what you have been using in DSEK. So here, the microforceps grasps the donor DM, pulls it into the eye, following which you place a small air bubble within the scroll, and then you can tap the surface to unfold it. This is useful in eyes which have anterior chamber lens, or it has anterior segment abnormalities where a normal untapping, unscrolling may be a bit challenging. You can have an S or an S stamp to identify the orientation. You can make the peripheral triangular notch, which is directed in a clockwise direction, or you can have asymmetric marks of 1 and 2 to help identify the donor orientation once it is unfolded. The other way to look at it is using an intra-op OCT, which is quite useful because in real time, you can look at the edge of your donor scroll and identify whether it's in the correct orientation or it doesn't require any further manipulation to flip it over. You do a complete air fill at the end of surgery to secure the donor. This can either be air or a 20% mixture of sulfur hexafluoride. Studies have compared both, and they've found that there is no toxic effect on the endothelium, and the rebubbling rate is definitely lower when you use a longer tamponade. However, you have to look at using longer tamponade carefully, especially in eyes which have hydrophilic IOL, because this can be associated with opacification of the IOL. And also, if you keep your pupil, if your pupil is myotic, you can develop posterior synechiae quite easily with long-standing tamponade. 8 to 12% of the patients can develop donor DM detachment, which can be partial or total. Partial is usually more common. You can look at the orientation of the peripheral scroll, which can tell you whether your donor DM is in the right orientation or it's in the upside down configuration. If your separation is more than 30% of the area or the central cornea is involved, you can do a rebubbling either using air or sulfur hexafluoride 20%, and this can result in a quick recovery from the corneal edema. So in conclusion, there are several advantages in DMEK over other techniques of endothelial keratoplasty. The faster visual recovery, minimal refractive shift, and reduced rejection rate makes DMEK an ideal procedure. A stepwise approach to learning DMEK along with proper selection of initial cases can make the learning curve easier for corneal surgeons. Thank you. Thank you for your patient hearing.